Welcome to this special edition of Diabetes Core Update, where we are going to discuss today an incredibly exciting topic, and that is medications in the cardiometabolic pipeline. That is medicines in the pipeline now for obesity, for diabetes, and for other cardiometabolic related diseases. This is an area that has truly become hard to keep up with, and it is more exciting than it ever has been, and it lets us, from a practical point of view, begin to understand the many ways that our abilities to help patients will continue to grow. I'm Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University, and this special edition of Diabetes Core Update is sponsored by Lilly. Joining us to discuss medicines in the pipeline, we are really privileged to have Dr. Juan Frias. Dr. Frias is the medical director and principal investigator at the Los Angeles Institute for Metabolic Research. He's been involved in diabetes, obesity, metabolic liver disease, and other metabolic-related research for over 25 years now, and has really authored an incredible number of studies, including being first author on the SURPASS-2 trial in the New England Journal of Medicine, the phase 2 study of orforglipron in the Lancet, the phase 2 trial of CagriSema in the Lancet, other articles he's been authors on in the New England Journal of Medicine, Lancet Diabetes and Endocrinology, Diabetes Care, Cell Metabolism. I could keep going, but I won't, because we want to make sure we have time to discuss our topic today. If you get it. If you read the obesity and diabetes literature, you have seen his name a lot. Juan, welcome back to our podcast. It's such a pleasure to have seen you last week at the ADA scientific sessions and to be doing this podcast.
No, absolutely. My pleasure. Really appreciate you having me back, and great to see you also last week, Neil.
Juan, you've been in this field for a long time. Before I dive into the information, can you share with our audience just how you got interested in clinical research?
Yeah, no, absolutely. I think like so many other things, it's people you meet, mentors you have over time. And I can remember even going back to medical school at Vanderbilt, a million years ago or 40 years ago, or whatever it was. My mentor there was an endocrinologist during my residency as well, an endocrinologist. So I just had a lot of people around me that were interested in metabolic disease and endocrinology. And then I was very fortunate to go to UCSD. My mentor there was Jerry Alefsky, who's a big researcher. And I started with clinical research in my fellowship and have continued it now for over 30 years. So I think it's the people I was around and a lot of interest in a growing field.
That is fantastic. Let's jump now into the pipeline, and we're going to really emphasize distinguishing characteristics of each medicine from each other. And we'll start with the multi-agonists. And let's first start with retatrutide, for which the data was announced actually last week at the ADA scientific sessions. Juan, tell us a little bit about
absolutely.
it.
So, we went from selective GLP-1 receptor agonists like dulaglutide and semaglutide to then tirzepatide, which is a dual GIP and GLP-1 agonist. And now retatrutide sort of takes it a step further, and this is a triagonist, so a triple agonist. It's a so-called unimolecular multi-agonist, so it's one molecule, but it's been engineered to bind to and stimulate or agonize the GIP receptor, the GLP-1 receptor, and also the glucagon receptor. And as you mentioned, there were some studies, a couple of studies that were presented last week in New Orleans at the American Diabetes Association scientific sessions, and really quite startling data. I can go through just the highlights of, for example, TRIUMPH-1. So the TRIUMPH program is the program looking at weight management, so people who are overweight and obese. And TRIUMPH-1 was a study in people without diabetes, so without type 2 diabetes, who were treated for 80 weeks, and then there was an extension, a 24-week extension. So overall, this was a 104-week study, which looked at body weight, but not only the change in body weight, but also there were what they call baskets or sub-studies within the trial looking at people with osteoarthritis of the knees and with obstructive sleep apnea. And what we saw really was the most significant weight loss that has been seen with any agent to date. So at 104 weeks, about on average with the highest dose, which was a 12 milligram once weekly dose, 30% reduction in body weight, with very large numbers achieving very clinically relevant reductions in body weight, up to 45 or so percent, having over 30% body weight reduction. And then also improvements in pain, so knee pain, significant improvements, and significant improvements, as you can imagine, in obstructive sleep apnea and the apnea-hypopnea index, which is the measure. So really quite startling results with retatrutide.
That really is. Now, I know we could talk probably for our whole 30 minutes about any one of the medicines we have on our list today, but we're going to jump now into our next up, which is Maritide. Can you tell us a bit about this compound?
Yeah, a little about Maritide. I don't think there was anything at the ADA, but Maritide is actually a GLP-1 agonist and a GIP antagonist. So sort of, tirzepatide is a GLP-1 and GIP agonist. So this has GIP antagonism, and it has a very long half-life. So it has been studied, and phase 2 was presented last year. This was in a New England Journal paper, again, for weight management. And the distinction here, not only the fact that it's a GIP agonist, or antagonist, I should say, is that it is once monthly, so very long half-life, and this provides a more potentially convenient dosing regimen for the patient. So again, very robust reductions in body weight with this in phase 2, and now it's in phase 3. So it'll give us another opportunity, again, with a different dosing regimen in this.
Fascinating. And we don't have time to discuss the nuances today of why one medicine with GIP agonism works well and the other with antagonism works well. But we'll leave that as a teaser for our audience to, at some point, we'll try to come back to and talk about. Next up, survodutide.
Yeah, so survodutide is an interesting molecule, and there are others like this, also a unimolecular multi-agonist, but now it's GLP-1 agonism with glucagon receptor agonist. So a dual agonist, which is GLP-1 and glucagon, and there were trials presented at the ADA, the Synchronize 1 study, which was an obesity study, and the Synchronize MASL study, which was looking at metabolic liver disease. And in these trials, about on average 12 to 15% reduction in body weight over time, so very robust with body weight reduction. But the glucagon receptor agonist is very specific to the liver. So the liver, glucagon receptors are highly expressed on hepatocytes, and it has some very interesting effects in people and positive effects in people with metabolic liver disease, as well as the weight gain. So probably the improvement you see in liver fat and potentially in fibrosis as well is sort of disproportionate to the amount of weight loss. And this is indicating that this glucagon agonism is having a real effect on the liver.
That's fascinating. So completely different mechanism with really a very different target organ than we've seen in other medicines we have. Then, next up, as we continue rolling on, CagriSema.
Okay, so CagriSema. So this now is not what we would call a unimolecular multi-agonist, so one molecule with multi-agonist activity. This is two separate medications in one dual-chamber pen. So this is semaglutide, which we know as Ozempic or Wegovy. So semaglutide with cagrilintide. So cagrilintide is an amylin receptor agonist. So amylin is also a nutrient-stimulated hormone. It's secreted along with insulin from the pancreatic beta cell. It has some very interesting central effects, to increase satiety. It also slows gastric emptying. It reduces postprandial glucagon concentrations. The bottom line is it has some very important metabolic effects to lower body weight and also improve glycemia and probably some other effects. So now this is a combination of these two. And there were several phase 3 trials that were reported at the American Diabetes Association. And these were called the Reimagine studies in type 2 diabetes. So very robust improvements in glucose, A1C reductions, in the 1.9 to 2.3% range, and very good weight reduction, particularly in patients with type 2 diabetes that tend to lose less body weight. So, up to 14% average weight reduction in these studies. So, and I will mention one other thing, that there was a study which is the Reimagine, I think it's a Reimagine 2 study. It is Reimagine 2, which compared actually CagriSema to semaglutide and to cagrilintide given separately, showing that the CagriSema, so having this combination, was more potent than semaglutide alone with respect to glucose lowering and with respect to weight loss. You have something a bit more potent by adding these complementary mechanisms of the amylin analog with the GLP-1 receptor agonist, semaglutide in this case.
That is fascinating. Juan, I can feel the anxiety rising in our listeners as they are thinking, I just got used to treating and talking to people about obesity and metabolic disease to begin with. How am I going to accommodate learning all of these new medicines, which is why we're talking about it. And to our listeners, we're not done yet. We got plenty more to still discuss today. So let's go on now to zenaglamide.
Oh, yeah. So there is also a combination that is a unimolecular. So it is a single molecule that is GLP-1 and amylin. So this amycretin, it's also called, again, in clinical development, and there is an injectable form and also, very interesting, an oral form as well. So this has been studied in obesity, in type 2 diabetes, and I think will be another potential oral option and injectable for patients. So unlike CagriSema, which are two separate medications given in one injection, this is actually a single molecule that is an agonist at GLP-1 and is also an agonist at amylin receptors, and again, a subcutaneous form and an oral form in clinical development, I have to say. So, we have to wait and see what happens with all of these medications. But like you mentioned, there's going to be a lot of them relatively soon.
Yeah, and that's interesting. And you mentioned oral, and we'll talk a little more later about other orals in development. But that's certainly something that many patients like the idea of. Now we'll go on to talk about some single agonists, and let's start with the single agonist from a new class. And I'm not even sure I'll pronounce this one correctly, so I'll probably need your help here.
Right.
Berobenatide?
Yeah, so berobenatide, this is an ultra-long-acting GLP-1 receptor agonist. So this is a selective GLP-1 receptor agonist, but it is ultra-long-acting. So ultimately will be given, or if the trials work out, it'll be given once monthly. And there have been data, phase 2 data. It's now in a program, it's called VESPER, which is a phase 3 program, looking at this for weight management again. Again, as with Maritide, it's a different molecule clearly, but convenience of once monthly dosing. So I think those will be very interesting data, but that's again in phase 3, so there's still some time. But we're seeing this move from, when we started, Neil, you remember this well, in 2005, it was twice daily, then we went to once daily, then we went to once weekly, and now we're looking at maybe once every 2 weeks or once every.
It's really amazing, Juan, because it just seems that there's so much innovation and complicated science essentially on the back end that allows us at the front lines to increasingly have medicines that frankly become easy to use, much easier than, as you said, this evolution from twice-a-day medicines to once daily to once weekly, and now we're even looking at once monthly, making things easier for us at the front lines in primary care and endocrinology, as well as, of course, our patients who are the ones that are taking the medicines and benefiting from them.
Yeah, I would say absolutely. So not only a range of different modalities of administration and regimens, but I would say also a range of different efficacy, safety, and tolerability as well, and maybe targeting other parts of this whole cardiorenal metabolic syndrome. So I think it will be more personalized, and we'll be able to say, hey, this person with really a lot of burden of metabolic liver disease may be better with this drug. This patient who maybe doesn't need 30% weight loss and has had issues with tolerability may need this drug. And this patient who really will only take an oral agent will have the other drug. So I think it'll help us to have all of this, to be able to personalize. It probably won't be that difficult. I think once they're out there and we learn how to use these.
Yeah, that's really fascinating and so promising. Let's go on now and discuss a few other medicines in the pipeline. And let's go to the single agonists that are in a new class of medicines. You mentioned amylin before in the context of CagriSema. There are now single amylin agonists. And remind us what amylin does, because for most of us, amylin is this molecule that we remember hearing about at some point, but don't necessarily know about it.
Yeah, so actually, amylin is very interesting. So it is a hormone, again, that's produced and secreted by the pancreatic beta cell. When we secrete insulin, we secrete amylin as well. It's got central actions which really control energy balance or food intake and satiety, slows gastric emptying as well, or regulates gastric emptying to regulate postprandial glucose and lipids. It reduces glucagon concentrations. And in fact, the first amylin analog, which was pramlintide or Simlin, was approved in 2005 for use in people with diabetes, but it was a 3 times daily injection in combination with or in conjunction with insulin therapy. So now we have these once weekly amylin analogs. We'd mentioned cagrilintide in the context of CagriSema, but cagrilintide on its own is also being studied for overweight and obesity, as is petrelintide, which is one that there was actually a phase 2 study presented at the ADA. So we're seeing 10+% reduction in body weight with these, just with the amylin analog. And a distinction, probably one of the important distinctions clinically, is very well tolerated. So you're seeing tolerability profiles that almost are mirroring placebo. There's slightly more nausea, generally during escalation, but withdrawal rates or stopping of the drug in these studies very comparable to what's seen with placebo. So amylin analogs are very well tolerated, and you're getting some very robust weight reduction, not retatrutide weight reduction, but very, very good weight reduction with these medicines as well. And there's several in clinical development.
Wow, that's amazing. And that really is, boy, would that be welcome, because that's the big issue for a lot of patients. And many patients just can't tolerate the GI side effects of GLP-1s.
Yeah, absolutely. So even on its own in some cases, but then again in combination like CagriSema, and there are other combinations now with dual agonists as well that are in clinical development, because the actions of an amylin analog and a GLP-1 or GLP-1 GIP are complementary, and used together they might even give more powerful weight reduction for those patients who need it.
Yeah. And, as we're talking about all these different mechanisms, it also reminds me that there are some patients, when we talk about means, those are always means, but that means there are some patients that either are non-responders to a given medicine or don't respond as well as a lot of other people. And we'll see as this continues whether or not these different mechanisms might work better for that group than the traditional GLP-1 or GLP-1 GIP dual agonist.
That's a great point. I always say, in these trials, the mean is usually the median. Like you say, you got some super responders, some that respond less, some that are, around the mean. But when we're in practice, sort of each patient is a clinical trial of N equals 1, and we need to individualize, see how they do. And it may be, to your point, the people who are not responding well may respond to a different drug. And in time, we'll learn more about that. But a lot of this we just don't know at this point. But it's nice to have other options to switch them to if they're not responding.
Yeah, so talking about individual preferences, let's now talk about oral agents.
Yeah, so oral agents, well, we've got oral semaglutides, but sort of the what we're seeing, or the latest kid on the block, if you will, is small molecule oral GLP-1 receptor agonists. And there's one that is approved, which is orforglipron, and it's approved now for weight management, either in people without diabetes or with diabetes. So this has the advantage that it could be taken with or without food, with no water restrictions, any time of day, because it's a small molecule, not a peptide. And there are a couple of studies for weight management that supported the registration and are published. A study called ATTAIN-1 in people without diabetes, ATTAIN-2 in people with diabetes, and very, again, robust weight reduction. In ATTAIN-1, for example, and at the highest dose, which in the studies was 36 milligrams, commercially it's a different formulation that's equivalent, but is 17.2 milligrams. There was an about 11% average reduction in body weight, with about 55 or so percent of the patients achieving greater than 10% weight reduction. Again, very robust. And all of these, I should mention, seems like the tolerability profile for the amylin analogs is better than the GLP-1 receptor. Okay, and we also have oral semaglutide as well that's been studied and approved for type 2 diabetes and also for weight management, and very robust weight reduction, now at higher doses for overweight and obesity, so 25 milligrams, and still a 14 milligram dose for diabetes, and here seeing very robust reductions in body weight that are over 10% on average. So very important oral agents, and then other oral small molecules that are in clinical development as well.
Juan, I don't know many people that could have given this type of overview in this amount of time. We're about out of time now. Do you have any final thoughts to the thousands of clinicians that have been really listening carefully to this and are feeling perhaps a sense of both excitement, but maybe also a little overwhelmed? Any final thoughts?
No, I think, it would be sort of a very overarching thought that obesity is a chronic disease. Most patients with the disease are not on medication or anti-obesity medications. So I think having all of these options is going to be important to be able to individualize therapy for patients, to get patients on these agents. And I would also say it's not just about the degree of weight loss, but it's the improvement we see with all of these drugs that have been seen kind of across the board with respect to improvements in lipids, in blood pressure, in inflammatory markers, in quality of life as well. So we're trying to really improve function, improve quality of life, improve cardiometabolic risk factors, and we're doing it with these medications at lower body weight. So I think it's an exciting time, and it's great to have agents available. And I think it'll all sort itself out. But I think we need to be really focusing on treating these patients.
I think that's such a good point, that overarching issue that right now less than 1 in 10 people who are eligible for these medicines are actually treated. Critically important. I'm looking forward to all these new choices, and I know all of our listeners and I as well learned a lot from our discussion today. Dr. Juan Frias, thank you so much for joining us.
Thank you, Neil.
And most of all, of course, as always, thanks to our listeners. Thank you for joining us on this special edition of Diabetes Core Update, where we discussed more in the pipeline than I think most of us had any idea was coming, that is there as a result of incredible scientific research and innovation that'll provide medicines eventually for our patients that will make their lives better. This special edition of Diabetes Core Update is sponsored by Lilly. We thank you for listening. For the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.